So SLE is a chronic systemic inflammatory disease where involve a multi-organ involvement, and it can be remitting or relapsing course. So it is very important for the obstetricians to understand this condition, is because the optimizations of the patient 6 months prior embarkment in the pregnancy can give a good pregnancy outcome. So for the diagnostic criteria, usually 4 out of 11 diagnostic criteria can diagnose the condition. So the first one, the mnemonic that I'm using is SOAP Brain MD. So for S is serositis, usually there's involvement of pleuritis as well as pericarditis. O is for oral ulcer, and A is for arthritis. Usually compared to rheumatoid arthritis, usually SLE involve more distal and small joints like distal phalanx. Compared to rheumatoid arthritis, usually rheumatoid arthritis involving a much bigger joint like knee joint, elbow. And for P is photosensitivity. Usually the patient is photosensitive because they will develop discoid or malar rash. And for B is blood parameters. Usually the features of the SLE is anemia, where we call it IHAS or autoimmune hemolytic anemia. So the features is the red cell count is high, and then there is a leukopenia of less than 4, and also thrombocytopenia less than 100,000. So for blood, and then R is renal or lupus nephritis. So lupus nephritis, usually the presence of proteinuria, but it is much more significant compared to preeclampsia because the protein will be more than 0.5 gram per day, or proteinuria of 3 plus solid proteinuria in the urinary family. And A is for ANA or anti-nuclear antibody. So the presence of anti-nuclear antibody is not specific or sensitive to SLE, but with the presence of it, we have to do more serology investigations or immunology investigation, which include anti-double-stranded DNA antibody to detect, and this is much more sensitive. About 70% of SLE might have the double-stranded DNA. And also we have to look for the anti-RO antilla, and preferably before the embarkment in the pregnancy, because the presence of anti-RO antilla or Sjogren syndrome A might suggest the risk of neonatal lupus or congenital heart block in the fetus, and it's affected about 2% of the fetus. And also the immunology parameters that we have to look at is the anti-Smith antibody, where it suggests a risk of lupus nephritis, and also C4 and C3 complement, which will be reduced in SLE. And furthermore, apart from immunology, RAN. N is neurologic. Neurologic will involve a risk of seizure and also psychosis. And M is for malar, and D is for discoid. So if the patients met this 11 criteria, 4 out of 11, then we have to discuss further on the effects of the SLE on the pregnancy and pregnancy on SLE. For SLE on pregnancy, the effects can be divided into maternal and fetal. So for maternal, usually the mother will have a higher risk of developing pregnancy-induced hypertension, diabetes if the mother is on a high dose of corticosteroid, and then the risk of VT is much higher in the patients, especially with the presence of APLS together with SLE. So APLS is conditions where you can diagnose when patients start to have lupus anticoagulant, anticardiolipin, as well as the beta-2 glycoprotein 1, and where you have to take the blood within 12 weeks intervals. And then the patients also can have higher risk of PPH, and also developing preeclampsia. For the fetus, the risk will be increase of the risk of miscarriage, about 75% of them, and then some of the fetus might ended up with fetal growth restrictions, stillbirth, IUD, as well as the preterm birth, and also PPRM. So for the effects of the pregnancy on the SLE, 1/3 of the patient might have relapse, where we know that during pregnancy there is a change of the immunity of the mother, where the T helper 1 will convert it into T helper 2, so this will cause SLE to be relapsed. And also 1/3 of them will have remission, and 1/3 won't change the initial condition pre-pregnancy. So it is very important for the patients to optimize the condition, because pregnancy itself, if pregnancy happened when the disease was not controlled, the patient might require immunosuppressive agents, high dose of corticosteroid, or the patient might worsen the kidney conditions during pregnancy. So the challenge for the clinician for SLE is because the feature sometimes is more likely like preeclampsia, but the treatment is different. For preeclampsia, usually the delivery of the placenta might resolve the issues, but for SLE, correct medications and control of the disease is much helpful than the delivery, and the pregnancy can be continuous, so we can reduce the risk of preterm birth if we know the correct diagnosis. So apart from that challenge, I think the management will be depends on one, the history. So the history, we as a clinician, we have to clarify with the patients when she was diagnosed with the disease, and how was her control, and what was the medication she was on. If she plans for pregnancy, usually we have to stop immunosuppressive agents that is teratogenics. For example, methotrexate, mycophenolate mofetil, and also cyclophosphamide and cyclosporine 3 months prior embarkment into the pregnancy. And the patients must be supplemented with folic acid about 5 milligram a day 3 months prior to reduce the risk of neurotube defects. And the patients can actually safely to convert into other medications like hydrochloroquine, azathioprine, and also prednisolone. But of course, we aim for a lowest therapeutic dose for prednisolone, because a high dose of prednisolone might also contribute to teratogenicity. So apart from the medications, the control of the disease, and also the supplementations, the mother needs to be emphasized about the potential sequelae to the fetus. And as we know that about 2% of fetus with the presence of anti-Ro might have a heart block, but the second pregnancy, if the first one was affected, then the risk will be much higher, up to 18%. So the expectations of the mother must be correct, and the understanding of the disease must be emphasized to the mother before embarkment into the pregnancy. So during first trimester, of course, a routine screening for congenital anomaly, especially the chromosome anomaly, is actually beneficial to the patient. But that won't exclude the structural anomaly. That is why during first trimester, of course, on top of the genetic screening, we have to do a preeclampsia screening as well by using a PLGF and also PEP-A, and also uterine artery pulsatility index to look for the risk of developing preeclampsia at 32 weeks. And of course, supplementations with aspirin, if the patients can reduce preeclampsia up to 62%. And if the patient does not have any chronic hypertension and compliance medication, basically we can reduce further down to up to 90% of risks of preeclampsia can be reduced. And if the patient's on calcium carbonate, for example, 1.5 gram alimentary per day, can reduce about 55% of preeclampsia. And of course, for Asian populations and Muslim with hijab, usually vitamin D is not sufficient, and supplementations with vitamin D is advocated by WHO about 400 international unit per day. And for Asian population, we use a higher dose of 800 international unit. And if the patient is obese, there is a role of giving an extra dose of vitamin D of 1000 international unit, or if the patient had underwent bariatric surgery, then we use 6000 international unit. So this is to increase the absorption of the calcium and reduce further the risk of preeclampsia. Of course, if the patient already gets into the second trimester at 20 weeks, we can take asplit to further increase the sensitivity of the screening to look whether or not the patient will develop preeclampsia within a week, so if the ratio is more than 38. And if the presence of anterior antilla and the risk of the fetal congenital heart block, then as early as 16 weeks, usually we can already started to do the ultrasound to look for the fetal heart, and also the M mode to look at the passage of the contractility. And of course, at 18 to 20 weeks, we have to do detailed scan and also the fetal heart scan to look at the four chamber and also structural abnormality in the heart. And of course, do a serial M mode ultrasound on the fetal heart every 1 to 2 weeks, starting from 28 weeks. And of course, at 36 weeks, usually we will have to discuss with the patient with regard to the delivery plan, which includes the timing and also mode of delivery. Basically, the timing of delivery, the patients can wait until up to term or date, 37 to 40 weeks. But usually at this point of time, usually we try to advocate a more complex obstetric case to be delivered at 39 weeks with inductions of labor. There is no contraindication for vaginal delivery in SLE patient. And cesarean section is an obstetric indications. Apart from that, we have to prepare the patient intrapartum during delivery. If the patient's on high dose of steroid, hydroprednisolone of more than 20 milligram per day, usually we have to give a stress dose of corticosteroid or hydrocort of 100 milligram 8 hourly, or if the patient's on prednisolone less than 20, usually we give 50 milligram 8 hourly until delivery. And postpartum, we have to watch out for any complications like the IVC as well as the BPH. And of course, postpartum, the patient needs to know that what kind of medication that she can take during breastfeeding. And basically, hydrochloroquine, azathioprine, and also prednisolone is safe during pregnancy. And of course, it is important to discuss with the couple with regards to the long-acting reversible contraceptive methods, whereby usually estrogen is much recommended to be avoided. Even though estrogen is actually safe in SLE if it was taken in the low dose of less than 35 microgram. But we want to avoid estrogen use, especially in the patients with history of VTE, the patients on currently active SLE or having lupus nephritis or what we call it, Raynaud phenomenon. So there are some conditions where we have to be extra cautious with estrogen. That is why as far as UKMEC1 is concerned, the recommended ARC for the patients with the SLE is intrauterine contraceptive device or copper IUD. But we have to be vigilant if the patient is on immunosuppressive agent, because there is a risk of infections for IUD user. So the key point here is the optimizations of the patient is very important pre-embarkment in the pregnancy to increase the outcome of the pregnancy.